Hello everyone and welcome to this week's and this morning's session of the World Antibiotic Awareness Week webinars. I think if anyone attended any of the ones last week, they must have been very excited to see that some really interesting things happening, and I think some excellent talks, and I do encourage everyone to go and have a look at those if they haven't already. Now, before we start, I would like to acknowledge the traditional owners of the land we are on today and pay our respects to their elders past, present and emerging. So for today's session, we have a very exciting lineup. I think everyone who knows anything about antibiotic stewardship always knows that surgical prophylaxis is always a more challenging area, and we don't always know why or how we can improve some of the prescribing in surgical prophylaxis. So I think hopefully some of our speakers today might shed some light on what's happening in the field, what we are doing to improve prophylaxis, and hopefully we get something out of this session which we might take forward for our users in our own facilities. So first up, we have surgical antimicrobial prophylaxis. Is there low-hanging fruit to be picked? This is going to be presented by Kristin Xenos. And Kristin is a Senior Project Officer in the Antimicrobial Stewardship with the AURA team at the Australian Commission on Safety and Quality in Healthcare. She's been working there since 2018, and prior to that, she was a Senior AMS Pharmacist for Western Health Sydney Local Health District in New South Wales. She has an interest in public health and a master's in public health and health management. She's also a fellow of the Society of Hospital Pharmacists of Australia, a member of the SHPA Infectious Diseases Leadership Committee, and in Advancing Practice Pharmacist Stage 3. In her spare time, she is a co-host of the Purple Pen podcast. And if anyone hasn't seen that podcast, it is really excellent and worth catching up on some of the presentations there. She also continues to work in community pharmacy, so she is very busy. So I'll start with handing over to Kristin now.
Thanks very much, Rod. So the title of today's talk is Surgical Antimicrobial Prophylaxis. Are there low-hanging fruit left to pick? And the reason why I went with that is because it's often described in clinical practice as, if you're starting off in AMS, you know, surgical prophylaxis is one of those low-hanging fruit that's easy to pick and easy to make quick gains in antimicrobial stewardship. So I guess we'll find out today if that's really the case or not, as it's often described. So I would just like to echo Rod's acknowledgement of country and begin by acknowledging the traditional owners and custodians of the land on which this video conference is hosted, and the traditional owners and custodians of the lands where the audience is may be located today. And I'd also like to pay respects to elders past, present and emerging. And I'm very cognizant today that a lot of the topics and content will overlap between all our excellent speakers. So I'm hoping to just kind of set the scene and not tread on anyone's toes too much, because these are, as you can see, will be the other topics for surgical antimicrobial prophylaxis this morning. So I think a good place to start is, well, why do we bother focusing on SAP? And I'll just refer to it as SAP from now on, rather than the mouthful of surgical antimicrobial prophylaxis. Well, it's pretty common. So surgery in Australia's hospitals, just looking at the year 2017 to 2018, 1 in 4 hospitalisations involved surgery. So that's a fairly significant proportion. And 59% of these occurred in private hospitals. And when you're looking at the hospital naps, it's one of the most common indications. And cefazolin, which is really the workhorse of surgical antimicrobial prophylaxis, consistently comes up in the top 20 antimicrobials year in and year out with hospital naps. The other issue is that we know that it is a real prevalence with inappropriate prescribing. So one of the key indicators of the Hospital National Antimicrobial Prescribing Survey, so the NAPS, is how much surgical prophylaxis is given beyond 24 hours, and that's our determination for best practice. And you can see there are some pretty consistent percentages. So we're really looking between that 26 to kind of 30% mark of one of those kind of key KPIs persistently being inappropriate within hospital naps. And hospital naps, given the rates of participation across the country, it's fairly representative of what would be going on in most hospitals, with variation between settings and contexts, private and public, to be borne in mind. Well, the thing that we need to think about as well is, why is it a persistent issue. And you can see here, this is a very complicated slide, and it's intended to be essentially illustrating there are so many players and moving parts which make improvement in surgical antimicrobial prophylaxis a really complex issue. So you can see that surgery touches many variables and many players within the field. So the anaesthetists and the surgeons, infection prevention and control issues within theatre, where are they moving to, their length of stay. You can see that there are many confounders to a potential surgical site infection, and post-operative antibiotic use is just one component of a very complex process following surgery. And moving on to why is it a patient issue? So there are many issues that arise from SAP being inappropriate and why it could be deemed inappropriate. So beginning with the antimicrobial that's been chosen is potentially too broad. Well, that's going to have some potential outcomes, including adverse effects. So generally antimicrobials that are broader in spectrum are going to have a more significant side effect profile and a more significant consequence for antimicrobial resistance. Is there a potential microbiology mismatch that wasn't picked up pre-surgery? Well, then we're looking at things like inadequate coverage and potential surgical site infections. Was the dose too low? That's another common issue following SAP being prescribed. And then we're looking at things like inadequate tissue exposure at the time of surgical site incisions. So that's going to be another issue leading potentially to an infection down the track. On the reverse side of that, the dose could be too high, and that could lead to things like toxicity. Then looking at incorrect timing. So the timing from knife to skin is really important with SAP to make sure there is adequate tissue exposure to minimize the risk of an infection post-surgery. The duration following surgery could be too long, according to guidelines. And then we're looking at things like adverse effects again, the antimicrobial resistance profile. And the reality is that there's a lot of evidence emerging that duration being extended doesn't necessarily correlate with preventing more surgical site infections. So the old adage of, if some is good, more is better, doesn't really play out in SAP and has significant consequences, as we'll get into a little bit later. Incorrect route. Again, we're looking at tissue concentration and allergy mismatch, as we would have learned from Friday's webinars all about antimicrobial allergies. There's a risk for the patient in that context as well. And then thinking about things, as we mentioned with the route, then we're looking at things like, those interesting applications of antimicrobials, whether that's washes or irrigations or bone cement, but we can get into that a bit later. And it's an interesting concept to think about concentration versus exposure, and that's why I've chosen the word exposure there, because concentrations can change over time. So we're really considering what antimicrobial exposure has the patient had, and I think that's a little bit of a more accurate terminology to use. So I spoke about this a little bit more. If some is good, then more is better, big question mark. And a lot of the evidence emerging looks at increasing duration of antimicrobial prophylaxis. We're looking at higher odds of things like acute kidney injury and C. diff infection in a duration and dependent fashion. So extended duration didn't necessarily correlate with a surgical site infection reduction, and that's some really important data to be communicating to surgeons and anaesthetists who are involved in the prescribing of SAP, because I think that would be one of the key motivators behind duration being extended for SAP. So stewardship efforts really should be targeting on limiting prophylaxis because we have the potential to reduce adverse effects without increasing surgical site infections. And when you think where people may be placed in hospital environments to make stewardship interventions, it's really going to be post-operative looking at duration. Not a lot of people are going to be well placed before knife to skin, unless you're looking kind of at a top-down, trickle-down approach. But if you're looking about where might some of that low-hanging fruit be that's relatively easy to pluck, I think this would be an arena where a lot of people would have more success, just because of the timing issue and the availability of people who might be making AMS interventions. And this was all really well described in the journal article at the bottom of this slide. And it was in JAMA, and it was, surgeons were involved in writing it. So it's kind of written by surgeons for surgeons. So I think that's a really bit of powerful information to consider and using in discussions. So thinking about the causes of variation for why we might have really variable practice with surgical antimicrobial prophylaxis, well, I think there are a couple of things to consider. So the ownership of risk for surgical site infections can be a little bit up to discussion and might change based on when your context is where you're prescribing. So in some institutions, it really might be the anaesthetist who considers themselves to be the one making decisions about antimicrobial choice. And in other institutions, it might be the surgeon. And I think that there might be a bit of, confusion sometimes about who might own that risk, and that can cause a bit of variation in practice because it's not clear. And then moving on to things like gaps in evidence for surgical prophylaxis. So that's why studies that I just previously described are really important to consider where there might be gaps in evidence and why that might potentially be driving practice. Workflow is another significant cause of variation, and you saw from the slide with all the different arrows everywhere that the workflow for a patient coming through surgery and receiving antimicrobials can be really complicated and be touched by a lot of hands, so it can be really difficult to try and make changes in that space and ensure that everybody who's involved in providing that antimicrobial to the patient is aware of what is best practice and who to target when making interventions. And that leads into antimicrobial prophylaxis is really considered a low priority when, considering the competing demands of theatre. There's lots of things going on, lots of things to coordinate in that environment. So often considering the appropriate dose and choice for an antimicrobial can be way down the list of priorities. And finally, the other cause of variation could be the surgeon's benevolence for an individual patient. So, a patient who is a more complex patient who is receiving multiple bouts of surgery, or it's a very, nasty surgical situation, the surgeon might be making an active decision to give more antimicrobial prophylaxis because they perceive that more is better for the patient. So that's where those discussions and having that evidence about more not necessarily being better and being associated with increased risk for the patient become really important. I'm pretty sure everyone who's worked in the surgical antimicrobial prophylaxis space has seen this slide before, but I really love it because it came from the Annals of Surgery. So again, taking ownership of the issue from within the surgeon community. So, this is written by surgeons for surgeons, and within their own words, opportunities for themselves to improve antimicrobial stewardship. So limiting perioperative antimicrobials to the OR, discontinuing the use of topical antimicrobials, having fixed duration after source control, discontinuing antibiotics after appropriate interventions. And you really want to limit antibiotics for things like uncomplicated diverticulitis. So for those specific indications where we know that we don't need those long durations of antimicrobials, and limiting treatment of asymptomatic bacteriuria pre-surgery is another big area for improvement in this space. Or limiting treatment for asymptomatic C. diff. The Commission has surgical site infections is a major priority within its area of practice. And within the Healthcare Associated Infections team, there's a great resource, Approaches to Surgical Site Infection Surveillance. And SAP is a prominent indicator that can be considered as part of a surgical site surveillance program. So when considering how to improve practice amongst surgeons and anaesthetists, there are some different ways that potentially you could go about it, and it really depends on what is appropriate and feasible for your local context. So these are just some of the ways that you might consider involving improving practice. So if you've got an antimicrobial stewardship committee, do you have appropriate representation from a surgeon, from an anaesthetist, from a theatre nurse, from someone in that space who can speak to these issues? And even if they don't have the time to be available for every meeting, could you make it that, you know, every meeting in May, it's a surgical month within the AMS committee, and you have to have someone from that space, you know, represented to talk to those kinds of issues. So that can be a really positive way to foster ownership of the issue within your facility. Collaboration on quality improvement projects. So rather than going full steam ahead, guns blazing on picking lots of low-hanging fruit in that surgical space without consulting anybody who works in that space. So without consulting anybody in surgery or anaesthetics, you might not find that the take-up be as you know, fervid, because they feel that there wasn't adequate collaboration, or it doesn't feel relevant to them, or you didn't potentially pick the issues that they consider a priority. So having that collaboration from the very beginning can be really useful, and involving them in the project design. So some surgeons might consider that prospective versus retrospective data collection be more meaningful, and having and kind of nipping those issues in the bud before they've got the chance to rubbish any kind of projects at the end can be, whilst it might be take a little bit longer to develop, it can be more meaningful and more sustainable because you have that collaboration. Involvement in writing a SAP guideline. So whilst there are really robust, wonderful national guidelines, sometimes even the act of taking guidelines like the Therapeutic Guidelines and putting them into your own facility's template and involving them in writing a particular guideline can really help with stakeholder engagement and create local endorsement of guidelines. So rather than saying, you know, we just use the Therapeutic Guidelines, you take that information and contextualize it to your facility and involve those key stakeholders in writing it and maybe making small adaptations to your local context, because it can be a really useful exercise in just creating engagement and endorsement. But, you know, that might not be, you know, needed in your facility, but it's just an idea. And creating a really robust forum for feedback to key prescribers. So surveillance and feedback of progress is really important in this space. So you might consider, where is a good opportunity to do that? Is electronic feedback, you know, well taken up and have a good channel for feedback to prescribers? Is there a grand rounds that surgeons and anaesthetists have, a meeting that you could attend, seeking out those kinds of that kind of information to make sure that you're reaching the key players at the best time for them is really important. And again, there are some general kinds of things that you can consider. So that might not necessarily involve surgeons and anaesthetists. So considering things like the surveillance of surgical site infections, and that could be with your infection prevention committee or combined AMS. Developing a targeted action plan can be really useful as well, just to kind of consider any kind of activity that might be useful. Circulating correspondence in your facility that's endorsed by hospital executive could be a useful tool as well. You might want to consider visual displays, whether that's in theatre or in imprest or in anaesthetic bays, wherever you're going to have that kind of high traffic and people looking at that kind of information, which might make them aware of resources and guidelines that they weren't aware of before. And reviewing your theatre impress can also be a very simple but effective tool to figure out what's up there, what's available to them, and you might be surprised by what you find. So I just want to talk a little bit about the Commission's surgical antimicrobial prophylaxis working group that was developed a couple of years ago. So it was developed in response to what we saw earlier of, surgical prophylaxis being a persistent issue with hospital naps. And so the Commission approached a range of organisations to target this issue, and we engaged with the following key stakeholders. So the Royal Australasian College of Surgeons, or RACS, Australian and New Zealand College of Anaesthetics, ANSCA, a College of Perioperative Nursing, Private Hospitals Association, NCAS, and relevant state and territory health department authorities. And some of the resources that were developed following the working group were really kind of simple but clear and tailored resources that worked really well, I think, to try to bring together some of the key persistent issues. And so I think that one of the great strengths of the working group was being able to kind of tailor the different resources to relevant audiences. So there were some opinion pieces that were published with the ANSCA Bulletin and the ACORN Journal. RACS invited some of the people from the working group to join a podcast to discuss the issue. We developed a PowerPoint presentation that could be customised by different health service organisations to present to key players, and we developed an infographic as well, which is available on the website. So considering appropriate dosages of different medications and some of the key issues of variation that we mentioned earlier. And all of those things are still available on the Commission's website under the Antimicrobial Stewardship tab, and also available at the end of the presentation with references. And stay tuned, because there will be a fact sheet emerging that is being developed with RACS on the issue of topical antimicrobial surgical prophylaxis. So that'll be a good resource to have as well. And I just wanted to mention as well the new clinical care standard for antimicrobial stewardship. So the refreshed version 2 of the clinical care standard will be coming out very, very soon. If I'm not mistaken, I think tomorrow or the day after. And it really kind of gets into surgical antimicrobial prophylaxis and has some wonderful supporting resources. So on the left-hand side of the screen, you can see that there's going to be a good pamphlet for consumers as well. So kind of different audiences will have different resources available to them in a language and terminology that they can understand. So the new Antimicrobial Stewardship Clinical Care Standard has this statement for surgical and procedural prophylaxis. A patient having surgery or procedure is prescribed antimicrobial prophylaxis in accordance with the current therapeutic guidelines or evidence-based locally endorsed guidelines, and this includes recommendations about the need for prophylaxis, so whether you need it or not, putting that right front and centre, because often, a lot of clean surgeries don't even need prophylaxis. The choice of antimicrobial, dose, route, timing and duration. So those are some really important concepts to bring together, and then considering the indicators associated with those. So that's how you might measure your organisation's performance to the standard. So looking at your choice of antimicrobial, the dose, the administration, and the how prolonged prophylactic antimicrobials are following the procedure. I mentioned the therapeutic guidelines before, and they've got, most people would be really well aware of the therapeutic guidelines, and they really do consider very specific circumstances for surgery and what organisms might be colonising different sites and making those customised recommendations. So it's, most people would know, but just reminding everybody that that's really the gold standard in Australia. The Commission also has an antimicrobial stewardship advisory related to surgical prophylaxis because it is such a prominent issue. So essentially the advisory says that health service organisations should ensure surgical prophylaxis is included and addressed as part of their AMS program. So it is a priority of the Commission as well and associated with accreditation. So just giving a little plug to the infographic that was developed a couple of years ago. So really trying to bring all those concepts we've discussed together, and it is co-badged by RACs. So trying to increase that ownership of the issue across the board for surgeons and people involved in surgical prophylaxis, consideration of infection control at the very beginning, the indication, what drug is being chosen, the route, the dose, and timing. So just kind of going through all those questions and putting those questions in the forefront of everybody's mind. I'd also just like to give a little shout out to NCAS for this wonderful resource that they developed in time for Antimicrobial Awareness Week this year. It's really wonderful and gets into the following topics: so timing, repeat dosing, calculation of duration, post-procedural, and requirements for general prophylaxis. And it really links in the concepts nicely to the surgical NAPS report, which I think Rod will be discussing a little bit later. So it's a really wonderful resource that I encourage everybody to have a look at. NPS Medicine-wise also has a really wonderful online learning module regarding surgical antimicrobial prophylaxis. It was revamped a couple of years ago, so it has had a refresh and is a really relevant resource. And I would encourage it to be shared amongst any of your colleagues who work in the surgical or anaesthetic space and who might be involved in prescribing SAP. So it's really useful because it is an online learning module. It's a little bit more accessible and not as kind of information dense as traditional channels. And also just a little shout out to the New South Wales Health Clinical Excellence Commission. They've got some wonderful resources on their website as well about fact sheets and guides for how to develop a guideline if that's what you choose to do, how to audit SAP, and how you might go about quality improvement tools. So just reinforcing that PDSA cycle, plan, do, see, act. So looking at surgical prophylaxis feeds really well into that cycle, and a lot of the resources from the CEC will help with that. They've also got some great templates for correspondence. So considering if you want to go about a memo or a letter or a position statement, you know, they've provided the template for you. So I would encourage everyone to have a look there. Okay, and then we're on to my references if anyone's keen to see where they all came from, but I think I've pretty much on time, so happy to take any questions.
Hi, thanks Kristin for an amazing talk and summary of what's happening out in the sphere of surgical prophylaxis at the moment. If anyone does have any questions, I do encourage people to use the chat option or the Q&A button down the bottom of your Zoom screens, and you can type any questions there throughout the anyone's presentations. We can answer them at the end. But I think I'd like to kick it off, Kristin. So there's an amazing amount of resources out there for surgeons. There's infographic sheets, there's, you know, summaries in TG, summaries in NPS, you know, CEC websites. Do we actually know if any of this is actually getting to the surgeons? I know the theatre nurses love them, pharmacists love them, AMS kind of techs love them, but do the surgeons actually have opportunity to view them? Do they respect them? Do they listen to them? Are we getting to the source of the problem?
Yeah, that's a really good question, Rod. And one of the things that's kind of been a priority for consideration when we developed the resources with the working group a couple of years ago, that was our real priority. And you know, it was a real kind of education for us as well to determine that RACs had their own, you know, learning and education and guideline committee, and that was a really important scaffold to kind of build ourselves into, and a really long process that we weren't really aware of. And I think that, you know, getting our information out into the channels that are already tapped into by surgeons and anaesthetists is the key to getting that information out there, because they may not necessarily be, you know, checking out the CEC website or the Commission website, or NPS medicine wise, as you say. So one of our priorities was embedding our own resources in the RAC's website and their curriculum, which is slowly kind of trickling through. And the other way was within the CPMC, so the Council of Presidents Medical College, so putting that information out there, which brings all the boards together. So from that top-down approach is kind of where we've started, but in terms of engaging in a grassroots organisation, I think because it's, the way that potentially people engage with surgeons is so variable from hospital to hospital, and what might work in one place doesn't necessarily work in another. I think that's where you need to tap into. When I worked at Westmead and we made some changes for our SAP guideline, we discovered there was a meeting at 6 o'clock in the evening that we didn't even know about, with all the surgeons and the anaesthetists coming together. So asking those questions about when those meetings happen in your organisation, I think are really key to getting the information out there to them.
Yep. So just a question from the NCAS group. How has the experience of communicating with stakeholders through the college and their media publications been?
Yeah, it's been good. I think that I've kind of had a bit of a fragmented experience with them, because we're on a real roll with certain things, and then I went off and had a baby, so I kind of had a little bit of a fragmented experience where I went to come back, and the people that I started engaging with were no longer on the same board. They were very useful and helpful to passing me on to the relevant people now. So that's where I've been engaging with them about the topical antimicrobial fact sheet that's coming out soon. And it's just been a matter of kind of collaborating and considering what their priorities are. And I think that my adage throughout the whole experience has been progress, not perfection. And I think stamping your feet about, well, no, this has to be the way that it's said and how everybody's going to take on that information. I think if you consider it as we're going to make progress, and then we can, everyone can come to a certain level together, and then progress can be made from there, as opposed to having negative consultation and really being stubborn about certain words and certain issues that you may not consider or appreciate where they're coming from and what their evidence is being exposed to. So I think making those kinds of negotiations and starting from somewhere and building upon that is a really positive step.
Yep. And I do think we'll touch on these aspects further on in some of our talks, especially from Trisha and Sim. So hopefully we can get some more enlightening on this issue before we finish this today's session. But in the interest of time, thank you, Kristin. Again, anyone puts any talks, any questions in the chat or Q&A, and we can even have a panel discussion at the end with Kristin again, if you think of anything in the meantime. But in the interest of time, we'll move on to our next set of speakers. And the next topic is dissecting the surgical naps. So this is a topic which is very close to my heart, as one of the people who's been working with the SNAPs for many years now, since its inauguration. But talking today will be one of our AMS pharmacists from the National Centre for Antimicrobial Stewardship, Fang. So Sin has been an AMS pharmacist up in Cairns Hospital for many years and has joined the NAPS team 2 years ago. So she's now an instrumental person in the surgical NAPS and the lead in the redevelopment, which she'll be touching on today. And also discussing will be this Courtney Ierano, Dr. Courtney Ierano, who is an ID pharmacist at the Alfred Health Hospital. Courtney is a rurally raised, trained and based clinical pharmacist who completed her Bachelor of Pharmacy with Grade 1 Honours at Charles Sturt University in Wagga in 2013 and went on to complete her pharmacy intern with Albury-Wodonga Health via Monash Health. Courtney has completed her graduate certificate in pharmacy practice with Monash University in 2015 and completed her PhD with the NCAS in 2020. So congratulations to Courtney for getting that ticked off this year during COVID. Courtney's PhD focused on the surgical antimicrobial prophylaxis in the acute tertiary setting, using a mixed methods approach to examining factors that contribute to inappropriate SAP rates, and hopefully we'll find out a bit more about her research today. But to start off with, we'll take it away, Sin.
Thank you, Rod. Just share my screen. Did that come out all right?
Perfect. Thank you.
All right. Good morning, everybody. So first of all, I would like to acknowledge the traditional owners of the land we're on today and pay our respects to their elders, past, present, and emerging. So for my part of the talk this morning with Courtney, I'm really glad to have the opportunity to talk to you about the surgical naps auditing tool, why it might be a useful tool for your facility, and how it differs but supplements the hospital naps too. I'll also talk about the surgical naps version upgrade that was implemented in the first half of 2020. I'll touch on some of the supporting documents that's developed as a result of findings in the 2019 Surgical Naps public report. Some of you have probably noticed that it came out around about 2 weeks ago, so it's pretty topical at the moment. For the next slides, I will just talk very briefly about surgical antimicrobial prophylaxis. So Kristin, in her previous talk, she's covered many of those topics. So just very briefly, we know that surgical site infections refers to infections at the site of a surgical operation that is caused by the operation. So it occurs in 2 to 13% of procedures in Australia, and 50% of those are considered preventable. It is considered one of the most common healthcare-associated infections. The National Surveillance of Healthcare-Associated Infections in Australia estimated that surgical site infections cost us around about $268 million per year, which is obviously a huge burden. So we know that prophylactic antimicrobial use has an important part to play in prevention of post-operative wound and deep site infections. Since 2013, results from the hospital maps demonstrated that surgical prophylaxis accounts for 11 to 15% of all antimicrobials prescribed in Australia. And the most recent surgical naps report shows that surgical prophylaxis was considered inappropriate in 43.3% of surgical episodes audited. So that's a huge percentage. That's just less than 50% of all the episodes where there is something that can be improved when it comes to surgical prophylaxis. We know that in practice, many procedures lack the evidence that surgical prophylaxis has any benefit in reducing post-operative infections, and their use is not recommended in national guidelines, so the TG. So for procedures where there is supporting evidence of benefit, a single dose prior to first incision is usually what is required, with the occasional recommendation for repeat intraoperative doses. There are very few scenarios where surgical prophylaxis should continue after surgical closure, and in those scenarios, the total duration of prophylaxis should not be equal or greater than 24 hours. So this is very much reflected in the TG guideline. So now I want to talk a little bit about the surgical naps. Surgical naps was developed in 2016 as a supplement module to hospital naps. It provides a standardized tool that allows healthcare facilities to audit and report antimicrobial use in incisional and non-incisional surgical procedures, and to investigate both procedural and post-procedural prescribing practices. So when conducting a point prevalence survey in hospital naps, you get a snapshot of what is happening at a set time in your chosen day of conducting the audit. So in contrast, the surgical naps allows you to audit the patient's entire surgical journey with regard to surgical prophylaxis. It is designed to provide flexibility to fit the workflow of different facilities. For example, public and private hospitals, facilities in metropolitan or regional areas, as well as surgeries including specialist services such as eye or ear centers. It also suits a range of surveyors, including pharmacists, nurses, doctors, anaesthetists, surgeons, and infection control personnel. So it's a very flexible tool that can be used to fit your purpose in your facility. So surgical naps went through a version upgrade in 2019, and the new version became available in the first half of 2020. So the way we approached this upgrade is we wanted to take on board our users' feedback in the previous years with the aim to make the tool more user-friendly and to improve its reporting functionality as well. So I thought the easiest way for me to show you some of what we did is just to bring up the tool. So this is the page. This is the page where you enter patient data in surgical naps. So you can see that once you've created survey and you're there to enter your patient's data, there's three main tabs: patient details, surgery details, and antimicrobials. So this hasn't changed very much compared to the previous version, but we have added functionalities. For example, we added in inbuilt calculators that will allow the user to say when a procedural antimicrobial was administered in relation to the time of incision. So what I mean by that, so for this particular patient, let's say he went through and had a total hip replacement, and the procedure was started at 8 o'clock in the morning. And if you go to the antimicrobials page, and when you're entering data for procedural antimicrobials, you're seeing cafazolin was started at 7:30. That is all good because it falls within the TG recommended administering time for cafazolin. And however, say if you change this to 8:30, which is 30 minutes after the incision, the system is smart enough to tell you that, give you this warning that says dose was given 30 minutes after the first incision. So this just eliminates the need for the user to go, oh, I forgot when the survey actually started, then try to go back to the previous page without saving this page and then try to work out the calculation themselves. It just makes it a lot easier for the user to assess this question here, which is the incorrect timing. So another example of improvements, we've built in checks and balances that allows the system to limit options based on the data that's already entered. So an example for this is if we move to post-procedural antimicrobials, and let's just say cavalaxin was given for this procedure, which is obviously not indicated. So when you open this up, and enter the details of cavalaxin, and you come to this question that says post-procedural antimicrobial not required. So if you didn't answer yes for this question, you have all those questions to fill out. However, in this case, if your answer to this question is yes, then everything just shrinks because there's no need for you to answer the following questions based on this, what you entered here. And the appropriateness of this cavalaxin is automatically selected to be inadequate, and that you can see that the user won't be able to change this. So this process just makes it a lot faster for users to enter their data, as well as it ensures the accuracy of the data that's collected. Because as you can imagine, we do receive orders with data like this antibiotic is prescribed, is not indicated, but somebody assessed it as optimal or adequate, then we're in a bit of a tricky situation as to do we contact the user to verify it? They have to dig out the paperwork. So by building it this way, we just make sure that all the data that's entered is actually accurate. So in addition to that, we have actually all three of the surgical naps reports have been entirely redesigned. So here is some of the screenshots that is from the current reporting functionality. So you can see that we've built in flowcharts that shows you, for the audit you conducted, how many episodes, how many were procedural and post-procedural antimicrobials, and you can see the data flow very clearly in terms of how many episodes and how many doses comes under each category. So here is an example of guideline compliance of post-procedural surgical prophylaxis prescriptions. So where you can see compliance with guidelines, the different categories that's divided by the surgical craft group. We've also introduced new reports or new graphs. For example, this one here is a box plot of the duration of surgical prophylaxis in patient receiving surgical prophylaxis. So if they did receive a surgical prophylaxis, what is the minimum, maximum, Q1, medium, and Q3 of your surgical prophylaxis in comparison to the comparator of your choice? So you set the parameters of who you want to compare against in terms of like maybe public hospitals or private hospitals, hospitals offering a particular surgery. So you set this yourself. And you also get to say what is the national box plot for the duration of surgical prophylaxis. So it allows you to say very clearly where you set and how you compare to others. And I should point out that this is part of the benchmarking report. So the benchmarking report now can only be produced for the procedures within a surgical group. That means you can't produce a report comparing orthopedic surgery against, say, urological surgery. The reason we did that is to make sure, the comparison is precise and meaningful. And in addition to all these new reports, you also still have the ability to export the entirety of all the data that's entered through an Excel export function. So should you want to produce your own report and dig into it a bit more, you definitely still have the ability to do that. So you can just export everything and pick on what interests you and produce the report of your choice. So that brings me to the last page of my part of this talk. So Kristin has touched on this as well in her talk. So through analyzing the data collected in the surgical naps, we found that incorrect timing accounts to 37% of the reason for inappropriate procedural prescribing, and post-procedurally, the most common reason were by far incorrect duration. So that was 56%. Antimicrobials prescribed post-procedurally continued for greater than 24 hours in 61% of the prescriptions, and out of those, 43% were continued for greater than 48 hours. So in essence, we identified that the main reason for inappropriate surgical prophylaxis prescribing was by far due to timing and duration. So timing and duration, you would normally think that is not a difficult thing to understand, but it can become complicated and confusing. So for prescribers as well as our auditors. So for example, what would you consider the start of surgery prophylaxis? Is it the time when the procedural dose was given? Or is it time of first incision? Timing and duration can become complicated when repeat doses are involved, by which the half-life of the antibiotic needs to be considered. So in some patients, existing antimicrobials and their administering time needs to be considered as well, because they may form part of surgical prophylaxis. So in response to identifying this gap, the NAPS team developed the resource, that's this one here, that's called Timing and Duration of Surgical Prophylaxis, which can be located just under the resource tab of surgical NAPS. So this document provides case examples, infographics, and explanations, starting with the simple cases and finishing with more complicated cases. So here is an example of a complicated case where, these post-procedural antimicrobials, that's appropriate, and so their timing needs to be considered, as well as the repeat dose, and that all needs to be considered in relation to the surgical incision time and surgical end time. So I do encourage you to check out this document while conducting your survey. It can also be used as a good training tool for your pharmacists and surgeons. So that brings me to the end of my talk. I'll hand you over to Courtney. So I'll just stop sharing. So yours, Court.
Hi everyone, so I'll just start sharing my screen. Alrighty. Thanks, Sin. So yes, my name's Courtney Ierano. I'm an NCAS PhD fellow. I'll be presenting some of the research outputs of the surgical NAPS data collected over the years. There's currently 3 public reports since the first paper pilot in 2015, and most recently the 2019 report was published 2 weeks ago to coincide with the lead up of World Antibiotic Awareness Week. This most recent report included over 140 hospitals, over 8,000 surgical episodes, in which orthopedics was the most commonly audited group. Similar to other years, incision time was poorly documented at 66.1% of the time. We're looking at prescribed doses. Procedural guideline compliance was suboptimal at 62.7%. And looking at post-procedural guideline non-compliance, this was inversely similar at 64.1%. In fairness, when we also discussed or looked at data where antibiotics weren't prescribed at all, guideline compliance was quite high with over 90%. In terms of common reasons for inappropriateness, timing of procedural doses continued to be the most common reason for inappropriateness, and for post-procedural doses, duration continued to be the most common reason for inappropriateness. And of those post-procedural doses, 61% were greater than 24 hours and almost 42.8% of doses were greater than 48 hours. In terms of published research, so as part of my PhD, I've been very fortunate to access and analyse the surgical NAPS data set. One of the first key papers that we did was to look at all the data we had collected up to that point in time, so June 2018, and wanting to describe the current rate of the surgical prophylaxis prescribing across Australia, and wanting to identify any hospital, surgical and patient factors associated with appropriate prescribing. We adopted a mixed effects logistic model and adopted an estimated marginal means analysis, which basically factored in all the variables in the model to provide us with an adjusted rate of appropriateness, factoring in all those factors. And that was then called an adjusted appropriateness. So what we found from this key project was that the crude appropriateness of all prescriptions was quite low, 48.7%. And when we adjusted for all the variables in the model, the adjusted appropriateness was also low and across all procedure groups. Comparatively, looking at procedural doses, the range of adjusted appropriateness was lower across the board, but more so for dentoalveolar surgery, 33.7%, compared to neurosurgery, 68.9%. And for post-procedural, the range was as low as 21.5% appropriateness for breast surgery and 58.7% for ophthalmological surgery. And similarly to other reports, timing, the most common reason for inappropriate for procedural doses, and duration for post-procedural. I think what was important about this paper was it addressed that misconception where I think a lot of surgical craft groups tend to say, oh, well, the rates are low because all our craft groups are lumped all together and every surgery is different. And what this paper found was that overall, yes, the rate of prescribing is considered poorly appropriate, but and it does vary between the craft groups, but there's definitely a lot of room for improvement across all craft groups. And maybe we need to then tailor our surgical stewardship interventions to these craft groups more specifically. So following on from this, because orthopedics continues to be the most commonly audited surgical craft group across the NAPS, surgical NAPS over the last few years, and we had a fair bit of data. And so we wanted to take the similar approach of the other paper to specifically orthopedic procedures. So we extended the data set to April 2019, adopted the same methods, but also included a subset analysis to get this adjusted appropriateness for each specific orthopedic procedure. And what we found, again, a low crude appropriateness of 58% across over almost 4,000 doses. And the figure here, I've broken it up into, so in black, it's procedural adjusted appropriateness, and in the light grey, post-procedural adjusted appropriateness for each procedure. And as you could see, even just within the orthopaedic and subspecialties, there's a great variation in appropriateness of pre and post-procedural doses. Noting the lowest rates were for knee arthroscopy diagnostic procedures, and for post-procedure or pre-procedural doses, ORIFs, upper and lower limb, had high rates of appropriateness. And across the board, post-procedural was again done quite poorly. So this paper is just highlighting that we do collect a lot of data, and with that data, we want to make this clinically meaningful for our surgeons, and we have the capacity to do that by breaking the data down and looking for trends and rates of appropriateness, not only just for surgical craft groups, but within them for targeted quality improvement projects. The final project, looking at the surgical NAPS data that was part of my PhD, was looking at antibiotic choice. So unsurprisingly, cefazolin is the most commonly prescribed antibiotic, which we're quite happy about because that's what's evidence-based and recommended by our Australian guidelines. But we also wanted to see, we could also see when you look at that data, there's a whole range of other antibiotics being audited and captured in the surgical NAPS. So we wanted to look at those, compare them to cefazolin, and were there any potential factors that were drivers for their use? Again, adopting the same estimated marginal means analysis, and the sub-analysis only included the top 5 antimicrobial / classes because these counted for over 90% of the data. So you can see in this figure here, the top 5, so in descending order, cefazolin counted for 11,000 doses, and then second up was metronidazole with only 862 doses. You can see I've put the broad spectrum sort of classes in the light grey and narrow spectrum in black. And again, you can see that there's quite a broad range in appropriateness. And even cefazolin itself still had an appropriateness of only 64.5%, suggesting rooms for improvement for other factors such as timing and dose and frequency. What we found was that there were various patient, hospital and surgical factors, but again, what was the driving factor were the surgical procedure groups, which identified key targeted areas for our broader spectrum antibiotics, such as abdominal and urological surgery to examine their use of 3rd and 4th generation cephalosporins. For aminoglycosides, whilst there are recommendations for aminoglycosides in surgery for specific procedures, we also want to be making sure that it's done appropriately and dosed appropriately. So looking across urological, breast and orthopedic surgeries, and similarly for glycopeptides, orthopedic and cardiac surgeries. So this just represents sort of, again, further niche surgical antimicrobial prophylaxis stewardship targets. In terms of future directions, looking in this space, the surgical NAPS continues to grow and grow more each year. There's ongoing analyses, public reports, and what's of interest is further subset data analysis. And if you look in the most recent 2019 report published the other week, there is an appendix that does sort of break it down per craft group, which I think is a great resource to have and for you to compare your practice to these sort of resources. And touching on what Kristin said earlier, we want to continue to collaborate with the Commission, RACs, and not just RACs, but other surgical specialty colleges, as we notice throughout our data that it's not just surgeons in general. We need to be targeting the specific specialties and engaging with them and wanting to optimize care. We've done a lot of work with the current upgrade and updating of the surgical NAPS, and that will continue to happen, and how we then re-engage with our end users and get feedback with them with these recent upgrades, but also with going into hopefully a post-COVID-19 era. I'll leave the floor for any questions, and obviously we'd like to acknowledge all our collaborators.
Thank you very much, Sin and Courtney. So an interesting breakdown of some of the NAPS data that we're pulling out. And I do think, yeah, it's really encouraging to see that we can actually start looking at some more kind of craft group analysis, because we do find that within surgical prophylaxis, each of the different surgical specialties do have quite unique prescribing practices, and actually education and training could actually target some of those. So if anyone has any questions, again, please use the chat or Q&A function. Another question from Mimkaz. So that's the same one. That's okay. So does anyone have any questions? We have one on Q&A. And that's from Glenn at the Epworth Hospital. And it's not a question, but just a big thank you for the new SNAPS tool and reports. Great stuff. So I do, yes, agree that the improvements that we made to the SNAPS was quite dramatic over the last year. So if anyone hasn't used the new SNAPS tool, it is a lot easier to use, we think. The reports are much better, and yeah, with some of those highlights that Sin's raised, the analysis of deciding what's appropriate and what's compliant with guidelines is much more simplified now, and the guide you along the way. So hopefully that's an easier tool to use, especially for the auditors which don't have great experience about surgical prophylaxis prescribing. So in the interest of time, I don't think we have any other questions, but I think we'll move along. And again, we're going to have a bit of a panel discussion at the end. So if anyone has any pressing issues to do with surgical prophylaxis, we can all answer them then. But I think there's another one. So from Kaz Thursky, just asking, are there any examples of feedback from surgical teams? We certainly don't know of any surgical teams which provide us feedback. We only get the feedback from kind of the AMS users, and because the people are only doing it this year, we don't know if people have had any great experiences of feedback from the surgical teams this year. We might get that more towards the end of this year after people have done more of their reporting. Again, I think this year was a difficult year. Most of surgical prescribing, elective surgery at least, was cancelled. So everyone's doing their surgical NAPS audits later in the year and about now. So we're only kind of getting feedback now as to what's happening. And I think people are kind of living up to this week and probably the next few weeks to be doing their surgical audits. So it'll be interesting to see what happens in 2020. It'll be the most interesting surgical prescribing, I think, because of the lack of elective surgery being performed throughout Australia. So unfortunately, we did release all the great updates for this year, and it hasn't been used as much as we'd hoped to, but we are definitely seeing a massive increase of people using it right now. So hopefully we'll get some feedback towards the end of the year. Okay, so I think we'll move along to our next speaker at this stage. So hopefully someone who doesn't need much of an introduction, Associate Professor Trish Peel, who's been a great collaborator with the NCAS for many years now and kind of heads our surgical stream. So she'll be talking about Mind the Gap, clinical trials targeting barriers to prophylaxis guidelines uptake in surgery. So Associate Professor Trish Peel is an NHMRC Career Development Fellow and an academic infectious disease and antimicrobial stewardship physician at Alfred Health. She was awarded her PhD and completed her postdoctoral fellowship at the Mayo Clinic in the USA. Her research is focused on improving patient outcomes, including the prevention of infections following surgery and optimization of antimicrobial use in healthcare and community setting. So she's definitely one of our great NCAS collaborators and the chief of the surgical stream, as I said, and I'll hear from her right now. Thanks, Trish. Take it away.
Thank you very much for that introduction. So I'm just sharing my screen now. So thank you for the opportunity to talk. And I think this talk dovetails in a lot with some of the talks before, and perhaps this isn't the low-hanging fruit. This is looking at clinical trials to try and address some of the gaps. So perhaps not the low-hanging fruit, maybe the high-hanging fruit, or possibly just destroying the whole tree. So it's certainly not an area that's overly easy to do these work in, but it's a very rewarding area. So again, just reiterating the reason why we're targeting this, we know that surgical prophylaxis is a common reason for antimicrobial use in the hospital. And it's an area where we have a lot of non-compliance with guidelines. And so a lot of our work has been trying to understand why our colleagues, our surgeons, our anaesthetists are not adhering to this guideline, and there's a lot of particular reasons for it. And so some of the work that we've done through NCAS and Courtney's wonderful PhD, as well as some of the work we've been doing at the Alfred, is trying to understand why surgeons and anaesthetists don't follow the guidelines. And there's two main messages that we get consistently from our surgeons in particular, and that's the responsibility, that they feel responsible for surgical site infections. They really do feel devastated when a patient gets an infection. And so they want to make sure they're doing everything they can to protect their patients. The second theme is actually there's not, the evidence is not complete, and there are gaps in our guidelines. And the other theme that comes through with the surgeons is when you talk to them and talk about the evidence, their automatic rejoinder is, but that's not relevant for me, or not in my hands. In my hands, I have better outcomes. So I think when we talk and when we think about our guidelines, I think we need to, and engaging with our surgeons, we need to make sure that what we're doing and bringing them on the journey to ensure that what we recommend is not causing harms and is going to benefit their patient. But I also think we need to be very aware of the fact that our evidence is not complete and there are big gaps in our knowledge. So trying to find ways to either fill that gap or allow some flexibility is important to bring our surgical colleagues along. So clinical trials is an area where we can really help to fill in those gaps. And I'm not going to talk through all the different areas of the components that make up good surgical prophylaxis prescribing, but I wanted to touch on three areas where there's work that we're doing to try to fill these gaps, and other groups have also done work in this area to try to fill these gaps. So I'm going to look at three areas: using the right drug, the right time, and the right duration. So when we look at the right drug, and I'm going to focus on a NHMLC funded trial that we're currently undertaking in joint arthroplasty surgery, the ASAP trial. And this trial is really assessing what drug we should be using in orthopedic surgery. The reason why we've done this is we know that the Therapeutic Guidelines recommend that prophylaxis should be targeting the most common organisms that we encounter, and that cefazolin is the preferred drug. And there's certainly great evidence to support the use of cefazolin. This is a placebo-controlled trial in hip replacement. I don't think anyone would be game to repeat a placebo-controlled trial in this sort of surgery again. But it showed that cefazolin was associated with a significant reduction in the risk of surgical site infections. But just note the date of publication, 1981. So since that time, surgery has undergone a significant evolution or revolution. Surgery has got more complex, our patients have got more complex, there's different types of procedures, but also, unfortunately, the bacteria we're encountering have also got more complex or perhaps more resistant. And so this is some work from a while ago from my PhD, which showed that in joint replacement surgery, we're seeing an increased rate of methicillin-resistant staph species, including Staph aureus and coag-negative staphs, particularly Staphylococcus epidermidis, but also organisms such as Enterococcus. And these organisms are important because they're not covered by cefazolin. From that work, there were questions arising, and from other groups, whether cefazolin was the best antibiotic for this group. And so the question arose, should we be using glycopeptides like vancomycin and teicoplanin rather than beta-lactams? And so this is some data from meta-analysis which showed using a glycopeptide reduced your risk of methicillin-resistant staphylococcal species and also reduced your risk of Enterococcus. But the big caveat to this, and I think it's well illustrated by this trial by Finkelstein, was when you change to using vancomycin alone, unfortunately, you see an emergence of MSSA and other methicillin-susceptible staph species. So whilst vancomycin is good for covering MRSA, it's a pretty lousy antibiotic for covering our methicillin susceptible isolates. So then again, the question arose, should we be changing our prophylaxis to dual prophylaxis? So a glycopeptide plus a beta-lactam antibiotic. And again, this is a cohort study by the Barcelona group, and they showed that in this cohort study, using combination prophylaxis with a beta-lactam, and in this case ticaplanin, was associated with a significant reduction in the risk of prosthetic joint infection overall. And interestingly, what they found was not only did it reduce the risk of methicillin-resistant Staph aureus, but they actually had no cases of Staphylococcus aureus at all. So those of us who work in this area and those of us who've been doing the SNAPs and NAPs for a number of years may have noticed that there's been a trickle of surgeons, particularly our orthopedic colleagues and some of our cardiothoracic colleagues, who started introducing vancomycin in addition to cefazolin as part of their prophylaxis. So whilst that may help reduce the risk, there's only cohort studies that look at it. There haven't been any randomized controlled trials. And importantly, none of these trials have really looked at what the downstream consequences of broad spectrum antimicrobials might be. They've also not looked at whether we should be targeting to certain groups or whether we should just be giving this dual prophylaxis to everyone. So this was the basis of the ASAP trial, which is a randomized double-blind placebo-controlled trial. It's been performed in joint replacement surgery. All patients are receiving cefazolin, and then patients are randomized to receive either vancomycin or a placebo. It's a pragmatic trial, which means we have minimal exclusion criteria, and we're not being overly prescriptive about any of the other care aspects. It's really just focusing in on whether they get the vancomycin or placebo. One of the nicest and I think one of the best elements of this trial is we're actually screening all patients on the day of the surgery for Staphylococcus carriage. And what I'm interested in knowing is, should we be targeting those people who are carrying a methicillin-resistant Staph aureus? Is that the group where we see the benefit, or is it everyone? And again, it's trying to make sure we tailor and target the prophylaxis to the most appropriate group. Obviously, in this trial, we're looking at outcomes such as surgical site infection, but also safety endpoints, including acute kidney injury. We're also looking for the emergence of vancomycin-resistant enterococci and also any other antimicrobial resistance. So trying to look at the downstream consequences. So these trials aren't small. You always need a big group. And so the target is just under 4,500 patients. We're nearly at the 3,000 patient mark. We're recruiting across 11 sites across Australia. And we expect to finish recruitment in around about June next year with the results by the end of the year. But in many ways, I consider this trial a win-win scenario. So if we are able to demonstrate that vancomycin reduces the risk of methicillin-resistant surgical site infections, I think that's important because it has important outcomes for the patient with reduction in risk of surgical site infection. But also we're doing this trial at a really important juncture where we know there is an impetus to start using vancomycin, but we're really building in the evidence, showing the evidence early on. So if there isn't a benefit, we can divest this practice early. Importantly, this trial also has very strong engagement from our surgical colleagues, including the Australian Orthopaedic Association. So we've brought them along on this journey with us. The second area that I want to look at is looking at right time. And this is an area, again, where we know there are problems with compliance with the guidelines. So we know with timing of prophylaxis, you want to have the antibiotic in the tissues at a good level prior to knife to skin. And so this is some data from the New England Journal back in 1992, where they showed there was this sweet spot where within about 2 hours from incision, or prior to incision, there was the lowest rate of surgical site infection. With shorter acting antibiotics such as cefazolin, this window can be narrowed down to between 0 and 60 minutes prior to knife to skin. And this is a cohort study published by Weber et al., where they looked at whether there could be some further refinement of this 0 to 60 minute window for short-acting beta-lactams. And they found that the lowest risk was in this 30 to 59 minute window prior to incision. The risk of surgical site infection increased when you went from 60 to 120 minutes, and also, interestingly, was increased when you went from 0 to 29 minutes. And for those who can remember the previous iterations of the therapeutic guidelines, they talked about this ideal window being around about 30 to 60 minutes prior to knife to skin. That's what sometimes can be challenging for the surgeons and from our anaesthetic colleagues. Often they don't necessarily know exactly when the surgery is about to start. Often they may just be getting the patient on the table, surgery starts, and they need to give the antibiotics quickly. So again, you know, there was some concerns about non-compliance because they were giving it perhaps too late. But I commend the group this authorship team led by Weber et al., who then not only did the cohort study, but went on to do the randomized controlled trial to really try to look at this. And this is important because they demonstrated that the administration of the antibiotic in what confusingly they called the early administration, which was between 30 minutes to 60 minutes prior to knife to skin, and the late, which was 0 to 30 minutes prior to knife to skin, there was no difference in the risk of surgical site infection. So again, it allowed us to feed back to our surgical colleagues, our anaesthetic colleagues, really support the evidence for timing of prophylaxis. So the last one I want to look at is right duration. And this is probably something that gives us as auditors probably the greatest headaches. It's an area where there is a lot of inappropriate prescribing, as we're well aware and as we've discussed in the presentations prior. So in 2016 and 2017, both the CDC and the WHO both released guidelines for surgical site prevention. And they both looked at the duration of prophylaxis as part of meta-analyses that they separately conducted. And both groups came out and recommended against prolongation of antibiotic prophylaxis after completion of the operation. So essentially, once the wound was closed, you stopped all antibiotics for all surgical procedures. And they based this decision on the moderate quality evidence that they had, but particularly they based it on the risk of adverse outcomes with prolongation of prophylaxis. And Kristin's already highlighted this paper, but I think it's a really important paper. It's a large cohort study which looked at the risk of complications with prolongation of prophylaxis. Importantly, the authors demonstrated that extending prophylaxis did not result in a reduction in surgical site infection, so it had no benefit, but it had harms associated with it, particularly increasing risks of acute kidney injury and C. difficile infection. So again, it's important to talk to our surgical colleagues to say it doesn't reduce infection giving prolonged prophylaxis, but it causes harms. But there's an important caveat to both these papers. And when you go and read in the fine print, and this is the fine print from the WHO, they highlight that there may be some evidence to support prolongation of the prophylaxis into the post-operative period with certain surgeries, including cardiac surgery. And that this is actually, when you go and look at the evidence, when you look at their meta-analysis, this is true. So this is a meta-analysis that was done as part of the CDC meta-analysis. And you see there's only 3 trials. They're small trials, but there is an evidence in reduction in the odds of surgical site infection, a 55% reduction in the odds of surgical site infection when prophylaxis is extended post-operatively. And so based on this, we know cardiac surgery is an area where there is an issue with prolongation of prophylaxis. And we went to our cardiothoracic colleagues through the Society of Cardiac and Thoracic Surgery, and we asked them, what do you think is the optimal duration of surgical prophylaxis? And over half said 24 hours of prophylaxis post-operatively. A smaller percentage said intraoperative only, but there was also about a third that said 24 to 48 hours. So there's a mix of opinions, and this is actually also reflected in the guidelines. So the WHO and CDC say intraoperative only. The Therapeutic Guidelines, the Australian Therapeutic Guidelines, say less than 24 hours. But if you look at the American Society of Cardiothoracic Surgery, they actually say up to 48 hours. So there's an area where there is a heterogeneous approach. When we asked our surgical colleagues, what is the major reason for you giving prophylaxis, or what determines your duration of prophylaxis? The leading reason they said was to prevent surgical site infections. So that was the key thing for them that determined duration. Other things such as antibiotic-associated infections, such as Clostridium difficile, was the next most common reason that influenced their decisions. Unfortunately, things such as antimicrobial resistance or allergies and intolerance were not ranked as highly by our colleagues. Importantly, though, we went back to our surgical colleagues and we said, if we were able to demonstrate that intraoperative only was as effective as post-operative dosing, would you change your practice? And so 80% of our colleagues said they either agreed or strongly agreed that if we were able to demonstrate that intraoperative only was as effective for preventing surgical site infections, that they would change their practice. So I think being able to show them the evidence, bring them along with us on this journey, involve them in the generation of this evidence is very important in order to change practice. And so born of all of these discussions and these linking with our surgical and anaesthetic colleagues, as well as our ICU colleagues, we are hoping to embark on a new trial, which is a little bit of a clinical trialist's wet dream, which is using an adaptive 3-arm placebo-controlled non-inferiority trial. And what we're wanting to do is look to see if effectively is intraoperative only associated with an acceptable risk of surgical site infection, but also harms compared to prolongation. And this trial is really being designed to reflect what's currently happening in practice. And we hope if we're able to involve our surgical colleagues, involve our anaesthetic colleagues in this process, that we'll be able to not only definitively get the evidence, but also be able to change the practice and improve duration potentially. Just as the last slide, I'd highlight that there is one other trial that's currently looking at this. This is a trial in knee arthroplasty, where again, there is limited evidence. And this trial is looking at whether 24 hours versus single dose prophylaxis in knee surgery is associated with a reduction in the risk of, or a clinically acceptable risk of surgical site infection. This trial was due to be completed October 2020, and hopefully we'll be seeing some results from that. So I guess, you know, it's, I guess just reflecting on all of this, the important messages I always have is I do believe in guidelines. I believe it's important for us to be doing, you know, consistent practice, standardized practice. But I think one of the reasons why we're seeing poor compliance with guidelines is that there is a lack of evidence in certain areas. And I've learned through this process is working with our surgical colleagues, acknowledging the gaps, trying to come up with trials that are meaningful for them, that answer their questions, and also engage them in the process is an important aspect. The other thing I would say though is these trials are not easy. They're obviously by their nature large trials, multi-center trials, take quite a long time to do. But certainly I hope that they'll be able to give us the answers and be ultimately rewarding. So just obviously doing this sort of work, we have a huge group of colleagues that we work with, surgeons, anaesthetists. So I'd like to thank them. We're supported by NHMRC in our work, and also I'd like to thank NCAS. My last slide is one I always put up when I'm talking in these sort of studies. I work a lot with surgeons, I work a lot with anaesthetists. And so on this slide is an infectious diseases doctor and an orthopaedic doctor. And I always like to see if people can pick who is who, which is the orthopaedic surgeon, which is the surgeon. So I'll stop there and happy to answer any questions.
Thanks, Trish, for going through some of that great evidence with us. And I do kind of agree that a lot of our surgical prescribing, if we actually used more evidence and actually brought our surgeons along with us, would definitely, hopefully, improve some of their compliance if they actually understand the reasoning behind it. I know one of our major issues, which we probably get a inquiry about almost weekly, and lots of confusion, is the differences between hip and knee arthroscopies. And the knees, they say there is no evidence to that less than 24 hours, where hips there isn't. And the TG does kind of suggest that for hips you stop after kind of wound closure, whereas knees you can go 24 hours. Do we think that sometimes consistent messaging might be better than following the evidence? Because this has actually led to a lot more confusion and to very, very similar procedures having different kind of requirements, and we get, you know, people are very confused. They don't know how to assess it. The surgeons get confused, and it seems to be a big sticking point in the current ETG.
Yeah, it is tricky, and you can go down a bit of a rabbit hole or trying to chase your tail or find the evidence. I mean, when you actually go back and look at the evidence for using prophylaxis in joint replacement surgery, there's a couple of randomized controlled, placebo-controlled randomized trials in hips, but there is no trial in knees. So no one's ever done a placebo-controlled trial in knees. So of course, we're not going to go back and do those trials. So you do extrapolate from hips to knees. But by the same token, in hips, there is evidence that a single dose is fine. There is randomized controlled trials in that, but that isn't in knees. So there are different operations. There are also a different patient cohort. So patients undergoing knees tend to have a higher BMI. You know, the average BMI for a knee patient is around 33. So, and with that comes, you know, increased risks of diabetes and so on. So they do have a higher rate of infection, and they're a more difficult cohort of patients. So you can again think, well, maybe there is some justification for extending prophylaxis, or perhaps it's more there's some confusion about whether there truly is a benefit with extending it or not. And I think that's why the Mayo group and the group in the US have gone back and actually looked at that area. But I know, I think also on a practical level, we don't have, you know, there's, and you know, you've written looked at all the procedure lists, and that procedure list grows, and you can't have a trial in every single procedure. So you do have to be a bit sensible and extrapolate like from like. But I think it's important when we do these is to go and talk to our surgeons and say to them, is a hip replacement the same as a knee replacement? Can I extrapolate one from the other? And they may say, no, of course you can't because of the following reasons. And I think that's important. You know, that's what we did with our cardiothoracic surgeons. We said, are you happy to stop? And they said, no, it's a completely different procedure. You know, these people undergo coronary bypass. They have universal endostemia and bacteremia. They go to ICU afterwards. So there's a rationale for why you might want to extend prophylaxis. So I think engaging and understanding some of the nuances of that surgery type is really important.
That's great. A couple of questions, I do believe. Oh, so Kristin's giving you a suggestion of which is the correct orthopaedic surgeon versus... So she's saying that the ortho guy is the one with the big gloves and the cigarette. Is she correct?
Yeah, she's correct. Yeah, that was Charlie, who's one of the ones who helped with the developing hip replacement. So yeah, it's interesting to see the different characteristics between surgeons and physicians.
Excellent. Okay, if there's no other questions on that, I think we'll move across to our next one. Thank you, Trish, for that again. So our next panelist and topic is tailored SAP tools, so collaborations with the New South Wales Clinical Excellence Commission. And this is from Sim Galliman, who is at the Wollongong Hospital and Central Coast Local Health District. So Sim is an antimicrobial stewardship pharmacist working out of Wyong Hospital on the Central Coast of New South Wales. And he has worked with antimicrobial stewardship infectious diseases for around 4 years, doing most of his training at the Calvary Martin Hospital in Newcastle. Sim has an interest around quality improvement projects in the infectious diseases space, in particular in patients with hematological malignancies. So I will now hand across to Sim for his presentation today.
All right, thanks very much, Rod. I'm just wondering, can everyone hear me?
Yep, you're fine.
Fantastic. All right, I'm going to share my screen. Page. All righty. So yeah, good morning, everyone. Thanks for dialing in. My name's Sim Galliman, and I'm a MS pharmacist working in the Central Coast, New South Wales. And I was asked to give some reflections on an opportunity I got to participate in collaborating with the CEC back in 2018. I looked to implement some quality improvement methodology for surgical antimicrobial prophylaxis projects. So hopefully in this presentation, I can give you some background on what instigated this collaboration, a bit on the quality improvement methodology we were implementing, who the team members were, and how the whole auditing process looked. So we can just go through the whole thing really. Yeah. So to start off with, I just wanted to give a little bit of chronological context behind the SAP project, not the surgical antibiotic prophylaxis project. I'll be calling it the SAP project because it's a mouthful. Right now, I'm one of 2 AMS pharmacists on the Central Coast, and I'm mostly based out of Wyong Hospital. And Nicole Cerruto is the other one, who's over at Gosford. For those not familiar with Wyong, it's about an hour north of Sydney and an hour south of Newcastle. And there are some pictures of Wyong up on the screen at the moment. At the moment, we've got a $200 million renovation happening, which is going to include a whole lot of new things like a new ED, an expansion of surgical services, which I thought was pertinent, and a whole lot more capacity just in general. But the thing I'm looking forward to most is that big hanging walkway, which looks pretty fancy. That little red arrow, I'm not sure whether it actually came up. Yeah, that's where the pharmacy department is, and that's where I am right now. Before this, however, I worked at the Calvary Martin Newcastle, and this is where the SAP project really took place. I was lucky because I worked in a really great pharmacy department, and there was some really great ID support, so it made things pretty easy when AMS projects and opportunities came about. The Martin just had a refurbishment of their own in 2015. The consistency and that little red arrow is where that pharmacy department is. Yeah, I guess what I'm talking about the Wyong Hospital and the MARTA, not only because of nostalgia, is because in September 2019, the MARTA was one of the first hospitals in Australia to be assessed for accreditation on the new NSQHS standards, which is the second edition of these standards. Yeah, and looking back on it, accreditation was the main driver behind why this project was pursued and eventually completed, or at least had its first cycle completed. Now, if you've never had the pleasure of going through accreditation or don't know what the Australian Commission or the NSQHS standards are, the ACSQHC is an Australian and state and territory government fund organisation that really just looks to contribute to better health outcomes for all patients and consumers. The standards of these tools by which it's consistent across Australia, and it's broken down into 8 sections, which encompass all clinical aspects of health service provision. And it's basically standard 3, which I'm involved in, which is infection control. And I guess it's a little bit of standard 4, which is medication safety, but I'll be concentrating on 3. All the standards are further broken down into actions and AMS is actions 3.15 and 3.16. Now, the hard thing about being one of the first hospitals to be assessed under these new standards was that if you don't really know, if you've never been one before, you don't know what to expect anyway. But if it's a completely new standard, no one knows really what to expect. So you really don't want your little sub-action responsible for the hospital not meeting accreditation anyway. So you really do everything you can to demonstrate the quality of the service that you're providing. So there's this looming assessment under a set of previously unencountered standards, which is the driving factor behind looking to get some projects up and running to show that AMS at MARTA was hopefully exceeded the criteria. Just at the time, we weren't really sure what sort of projects might actually do this. Yeah. But funnily enough, as we were thinking about potential projects to demonstrate, this email came through, and it was an advisory released in November 2017 by the Commission regarding specifically surgical antimicrobial prophylaxis and its place within the actions 3.15 and 3.16. This was ringing a few bells at the time because we were obviously looking for projects to show that we satisfy the criteria. But it was the assessing organization releasing an advisory saying, here are specific areas you need to show you have clinical oversight and governance in. So you can see up there, I've highlighted the specific indicators which they wanted to show. I'm not sure if you can see those indicators up on the screen, but I'll refer back to them later anyway. So the impending accreditation had us on high alert for potential products, and now this advisory gave us some obvious clues as to where to focus our efforts. I guess the next thing the MARTA AMS team needed to figure out was how to really go about doing this. So pretty soon after this advisory was released, the CEC happened to send out this email. It was basically a call for expressions of interest to test out these new resources that the CEC was developing for SAP improvement projects. And at this point, I kind of believe you make your own luck, but this was an instance where I'm not too sure. With preparations for accreditation beginning and some brand new standards that come out, which people didn't really know what to expect. Then the Commission tells us what would be a good idea to focus on, and the CEC emails us saying we've got some new quality improvement tools. It's just a bit, it was all a little bit weird. Anyway, so I emailed Lolita too, who is the AMS officer at the CEC at the time. She's on mat leave at the moment. I think Bayan might be covering her. And after a few back and forth emails, it was clear the first step would be we need to identify the key stakeholders involved in the surgical process and ask if they'd be interested in having representatives take part in this little prophylaxis project. We identified the stakeholders, sent out some calls for expression of interest for a surgical antimicrobial prophylaxis project as a mandatory component of accreditation. So there's some strong words there, mandatory and accreditation, and I think this definitely caught some people's attention. So we really quickly had representatives from all the departments we identified. Accreditation might be a stressful time for everyone, but it's a good tool to get things done in a fairly timely manner. So there's good sides to it as well, I guess. But it could also be another part of my luck, as not only was it at this time we had a fairly strong AMS department, we also had great support from anaesthetics, surgical quality manager as well. So yeah, again, it's just things coming together well. So anyway, once we had this team finalized, we organized some times for Lolita to run some quality improvement methodology tutorials with as many of the team members as we could get. But there's a lot of departments, so it was hard to get everyone together at a time. But we did have a lot of people attending, and probably the main people attending was myself, the team leader, project leader, John Burston, the ID physician, Alison Armstrong-Brown, who is the director of anaesthetics, and Richard Hanlon, Dr. Richard Hanlon, who was an anaesthetics advanced trainee and in ICU at the time. And it was good because those were the main leaders of the project. So Lolita ended up breaking the sessions down to short, kind of 30-ish minute teleconferences around a week or two apart, and divided the sessions into what's up on the board. So kind of into mapping models, data measurement, and PDSA cycles. So yeah, each session we applied these kind of different concepts to our projects, and as we went as best we could, And then in between sessions, we would kind of further develop our ideas. So the first session that she ran involved developing a process map to get a visual representation of the steps involved in patients having a surgical operation. This kind of allowed us to see what steps and areas were potentially involved when it came to surgical SAP, and move on to further explore, I suppose, contributing processes to it. We ended up breaking it down into fairly generalized, simplified steps, as you can see on the screen, and they're color-coded by which health professional was primarily involved and responsible for the kind of coordination of that step. We then identified in which of these steps would there be any potential contributors to changing how SAP is prescribed, and found that there were really quite several. So looking at some of these steps with the red stars, examples of pre-op preparation might involve checking patients' height and weight to work out doses, or checking allergies, anesthesia induction in the operation itself for the times antimicrobials were actually administered, which is very important when it comes to prophylaxis, and how post-op card on the ward might work. Yeah, so it's like how long prophylactic antimicrobials were continued for. Yeah, these were fairly obvious steps to point out, but we found that there were really more, even like kind of subtle steps with specific areas, such as during the timeout step, we found out that the responsibility of which antimicrobials we use and who prescribed it wasn't always consistent. Like who would decide on it? Sometimes the anaesthetist would decide, sometimes the surgeon would decide. Another issue we found out was that if a repeat dose of antimicrobial was required for longer surgeries, then it wasn't consistent again about who was responsible to keep track and say this needs to be given. Another issue we found was if the PACU report specified that antimicrobials were to be continued for a certain period of time, this message wasn't always solidly passed over to the on-ward team. And if there were measures to make sure it wasn't continued longer, yeah, that wasn't consistent as well. So it was these kind of brainstorming sessions that we had with the representatives from different departments, which was really useful to kind of get these issues out. So in saying that, the process map was a great way not only to get everyone on the same page, but educating everybody regarding areas they might not be as involved with in the surgical process. So now that we'd identified areas that might contribute to inappropriate prescribing, the leader asked us to go away and try and think of some more specifics from these areas, and then use a cause and effect diagram to group them into 6 themes. To be honest, I've lost the actual diagram of our own, so what you see on the slide is the example diagram that the leader gave us. But I do remember ours being almost exactly the same, so yeah, there's that. Of these, there were several that stood out for several reasons, from simple things such as AMS not knowing that SAP guidelines weren't readily displayed in pre-op rooms, to more complex issues such as, I guess, hierarchical structures that weren't necessarily conducive to questioning prescribing, or interdepartmental relationships, yeah, a bit more complex things. So this, combined with the process map, really lent to getting a good insight into the kind of broader and also more specific causes leading to inappropriate prescribing of antibiotics and surgical prophylaxis. So now that we had a good idea about the kind of problems we needed to investigate, the next step was figuring out how we would go about investigating these. And funnily enough, the leader already had the next suggestion, which was using a driver diagram. A driver diagram, for people who've never used one before, it's a visual tool that can be used to both identify problems, scope a project to address these problems, and clarify a plan so that any relevant solutions can be devised to achieve your aim. I need to apologize again. I couldn't find the original file with our original diagram, but again, it looked very, very similar. And I guess we're not looking at specifics of mine, just this is the methodology. But you can see the target rate of 95% appropriate prescribing for surgical antimicrobials was set, and also a time frame in which to achieve this, which I think was important, having a goal. So we chose the same because we wanted to do this to be an ongoing process of review, and you'll see why later. Apologies if the slide is a bit hard to see did identify several of the primary drivers, which were concepts mainly based around primarily knowledge, communication, and standardized process. And then we identified secondary drivers, which were mostly generalized actions we could take to facilitate the primary drivers and subsequently improve our chances of reaching our eventual aim. So after this, we brainstormed around specific tasks or change ideas, as it's labeled. We could link those to secondary drivers, and then we found in the end we had some interventions with the potential of achieving our aim. But this was all potentially getting a little bit ahead of ourselves because we needed to find a way to measure if these interventions would make any difference. And to do that, we'd need to see where our starting point was, really. So this moved us onto the next part of the QI methodology, which involved data and measurement. This is probably the most important part of the methodology because you can't improve what you can't measure. Now, when I was thinking of this, I honestly thought I came up with that quote, but then I put it into Google and then realized I probably heard it off this guy. So this famous mathematician, did a bit of work in thermodynamics. Yeah, I guess he's kind of famous. But the fun fact was he was the first scientist to be elevated to the British House of Lords. A bit of trivia for you. So there were a few key questions that we needed to answer. We met virtually with Lolita for the second time, and she ran a really good session with us regarding the different types of measures, in particular looking at outcome measures, which in this context would be the consequences for the patients. Process measures that looked at factors that contribute to the intended outcome of reduced surgical site infections, and balancing measures, which looked at changes to the surgical process that result from the first two changes we looked at, i.e. the outcome and the balancing measures. Sorry, the outcome and the process measures. However, as we went through it, we realized we were already doing the outcome measures by continuously and recording and periodically reporting the percentage of surgical site infections and adverse outcomes. We also realized we couldn't look at balancing measures just yet because we hadn't implemented any changes. So as we concentrated on process measures, as we thought about what we needed to measure, we referred back to that advisory that the commission sent around, making sure we took that into account. So we needed to think of something which, if we were going to do some measuring, looked at the rate of documentation for prescribing prophylactic antimicrobials, accordance with guidelines, timeliness of administration, and appropriate cessation. So the more we looked at this and discussed, and coupled with a little bit of gentle direction from Lolita, we quickly realized there was already a pretty good tool that we could use to measure all that we really needed to. So there is an organization called the NCAS, if you haven't heard of them. I've done a bit of work around pretty much everything AMS, and they're pretty amazing. They've got this amazing tool to assess the appropriateness of surgical antibiotic prophylaxis, if you haven't used it before. Yeah, I've mentioned like a few times, if there's existing tools that fit your purpose almost perfectly and save you a lot of work through no real intent of your own, again, it's all a little bit too lucky. So the next thing we needed to do was focus on what type of surgeries we were going to audit. So we had our tool, we just needed to figure out what we're going to concentrate on. The surgical and anaesthetic representatives of the team were probably the best people to lead this aspect of the project, and they suggested asking medical records to compile a list of patients who had undergone what they thought was the most common surgeries. And they happened to be at the MARTA, abscess surgeries, appendicectomies, cholecystectomies, colectomies, hernia repairs, and stoma formations. The representatives also suggested doing years worth of data because they felt that they would probably give enough statistical power. And if not, at least it'd be a good starting point and we could go further if we needed to. And on the slide, you can see surgeries, the numbers performed from the 1st of January to the 31st of December in 2017. Because at this point, we needed to further refine our sample to try and remove as many confounders as we could. In the end, we decided not to look at abscesses just because those numbers is pretty much abscesses from lots of different anatomical sites, and there was lots of several different risk groups, which would have made judging it a bit more complicated. We couldn't really trust the homogeneity of the group. We also needed to make sure that when we were going to stratify by surgeon, that we had enough of each surgery to give us the best chance of statistical inference. So we decided not to look at stoma formations because many of the surgeons who were involved in that weren't involved in the other surgeries. So we got rid of those two, and once we had stratified all the surgeons and looked at the numbers, we identified 7 surgeons as having performed enough of the 4 types of surgeries for what we want to look at. So yeah, at that point, after a quick few back and forth emails between the team members and finding people who were available to audit, we I randomly allocated particular surgeons and specific surgeries to different people. So in the end, it was the 4 main people: myself, Richard, John, and Alison, who did most of the auditing. And once an audit had finished with their assigned audits, they just helped the other people out just to finish it off, which is what Richard did because he did quite a few. So yeah. So those are the results that we kind of had. Sorry, I must have skipped some. Yeah, so those are the kind of numbers of appropriateness that we had for our different surgeons and our different surgeries. If you haven't used one of the NAPS tools before, appropriateness of 1 and 2, those are the numbers. 3 and 4 are not so appropriate or inappropriate, suboptimal. But yeah, those numbers, you got to look at them with a grain of salt because some of the numbers had lower amounts. So the majority of the analysis we did was looking at individual doctors as all their surgeries, all their types of surgeries, or the type of surgery by all the doctors. So it's really more of the averages that we have there that we looked at properly. But yeah, those are the kind of numbers which look good in some ways and bad in others. So on the slide of the results we got, it's a different one. So we critique the surgeries either optimal, which in all the surgical naps denoted by 1 or 2, and this is probably the handiest thing that we had. It's just the easiest way to see whether something's appropriate or inappropriate, but I'm sure many of you have seen that before. So at this point, we felt that we had enough data to finally run some stat analysis. To be honest, John Burst and the ID physician did most of it, but from what I can remember, we decided to run a chi-square test to see if there were any association between our independent and not dependent categorical variables. So whether there was an association between any surgeon and inappropriate antimicrobial use, or any surgery and inappropriate antimicrobial use. The results of most interest are up on the slide, and we found a few. Firstly, we found that appendicectomies were the most likely surgeries to receive inappropriate post-operative antimicrobials, mainly due to duration of surgical antibiotic prophylaxis. We found that documentation of antimicrobial administration was really hard to interpret because of the handwritten anesthetic charts. Now, the anesthetic chart I've got on the slide is the Central Coast one, but the same format was used at the MARTA. Getting as exact possible times of administration can be really important when it comes to administering before knife on skin, as you can only estimate what they're intending to document. But yeah, unfortunately, there are times where an estimation isn't exact enough and it's kind of hard to interpret. I'm sure other people have come across this problem. So yeah, I'd be really interested to hear how anyone else has dealt with that. It's ongoing. The final thing I'll mention, though, and probably most interesting for us, is that we found one surgeon who had a statistically significant inappropriate prescribing of post-op antimicrobials, and we had one who was statistically significant appropriate prescribing of post-op. So with these results in mind, we needed to figure out how to use these best to achieve some tangible improvement in the SAP process. So yeah, it was after this analysis period that we ran our third and final session with Lolita, and it was to do with the old PDSA wheel. So most people who have done any sort of quality improvement project might have come across the PDSA cycle, but it's really just taking the kind of scientific methodology of inductive and deductive reasoning and simplifies it into repeating 4 steps again and again, which kind of makes incremental improvements to achieve one large greater scale improvement. So at this point, we just finished the study part of our cycle and we're up to act. So we need to decide what changes need to be made and when the next cycle was to run. So firstly, we need to figure out how to best feedback this information to surgical anesthetic departments, as their prescribing was the primary focus of this. Luckily, we had our representatives who did this at their departmental meetings, and in turn, we got feedback from them as well, with several immediate actions we could take, which, funnily enough, aligned with the interventions or change ideas we had initially identified in our fishbone and our driver diagrams. This included putting a summarized SAP guideline above scrub sinks for quick reference for surgeons, finding out with IT whether it's possible to enter exact times of SAP administration into IPM, which is their central electronic database they have there for patient information. Running some education sessions with the junior staff, so hopefully trying to pass some good practices to the next generation of surgeons while getting them to be a good reference point for the senior ones. And looking at other surgeries, with the first being breast surgeries, because anaesthetics have mentioned there's been some unusual regimens there, and AMS had as well. And finally, to repeat the process once all these initiatives have been implemented. So this last suggestion was really encouraged as encouraging because having a department welcome cyclical analysis and feedback doesn't always happen, but it showed a real willingness to engage with ID and AMS, which happens to fit into our PDSA cycle really well. We gave ourselves a realistic target of repeating the audit in a year, so we could accumulate data from a year's worth of surgeries, so we can make it a bit more comparable to the first audit we did, which had a year's worth of surgeries, and yeah, it's just a bit better. So now that we've come full circle, we can return to why we did this in the first place, to be honest, which was accreditation, not gonna lie. But yeah, in September 2019, 3 reps from the German Council of Healthcare Standards hosted to the MARTA and assessed us on the second edition of the NSQHS standards. I was only responsible for my little part of the standards, but my experience was actually surprisingly quite pleasant. I mean, the assessor assigned to standard 4 was really nice. We talked about the AMS program at the MARTA, spent a bit of time going over the SAP project, what we were aiming to do, how we did it, what our results were, and what we were going to do from here. Yeah, to be honest, it was my first accreditation, but I was surprised at how pleasant it was. But in saying that, you know, the quality manager probably was a bit more stressful for her, but AMS was fine. But yeah, the most important thing in the end was that we got the pass marks for AMS, and the surgical SAP project was definitely a big contributor to that. Yeah, and on a side note as well, we submitted a project for ACID in 2019, and John Burston, the ID physician, went up to present it. So all in all, a good outcome. We achieved our main goal of satisfying the accreditation standard, but we got a poster presentation out of it, which is something as well. Yeah, so since this is my last slide, I just wanted to say that this collaboration I thought was a really useful process. It was good to not jump blindly into a quality improvement project and actually had some steps to follow with someone guiding you. Knowing what came next made things a lot simpler. Especially when it came to coordination of the project, so you could know what was coming and you could know what to do. Yeah, I also wanted to take this chance to thank everyone involved in the project, especially John, Alison, and Richard, who did lots of work with me, for Lolita for running the methodology, for Bayan, thank you for inviting me to speak and sending me those methodology slides that I've lost, and everyone to the MARTA, and everyone listening for sitting through this. Yeah, I've almost definitely forgotten some aspects of this project, but yeah, if anyone has any questions, be happy to answer them.
Thanks, Tim. It's really interesting to see how kind of these processes can be implemented, and I do think collaboration and pulling tools and resources which have already been developed is really the way to go in surgical prophylaxis and in many other quality improvement initiatives. And I think it's really excellent what you've done. One thing I can really answer for you with some feedback from these surgical NAPs is the documentation, and it is always difficult. The paper charts were terrible, but what we're hearing is actually sometimes the electronic ones are even worse, where there's actually no places to actually record times correctly, and they definitely weren't built with quality improvement initiatives in mind. And we are finding that people with electronic prescribing is actually finding it harder to do the SNAPS audits, because sometimes there is no ability to actually work out when the antimicrobials are given, or at least on the paper chart there's some kind of vague spot where there might be written, and there might be a 15-minute gap where they can actually see that the antimicrobial was given. So something we just need to think about is that as we do move towards electronic prescribing, they do need to be improved, and some aspects of these are not always optimal for our quality improvement initiatives, but hopefully we can improve those over time as well. One of the questions from Inkaz is, how was the experience on the feedback sessions? How were the surgeons in those discussions?
Apparently it was well received. I didn't attend the actual the departmental meetings myself, and the representatives kind of gave a little feedback report, and I guess it kind of helped that it was coming from their own representative about what was happening. So I guess it was kind of their own little their own little clan, which probably helped. But yeah, I kind of didn't really, besides the initial expression of interest call, communicate with the department directly. It was all through the representatives, which seemed to help, and they were really surprisingly welcoming of feedback. So
there's a common theme through our talks, is that you can get the surgeons involved early, get them in the middle, and get them at the end, and things will hopefully be better.
Yeah.
I do have an interesting question, and I think this is probably something we can probably open up to all panelists, but I can definitely start with the questioning. So we have a question. So what is the starting point of introducing surgical prophylaxis AMS initiatives in low to middle income countries? Which I think is really interesting. And I think from our experience, you've got to start with the small things first. So, and things which have the best evidence. And I think, as Trish has highlighted today, probably the first one is timing. If you can get them to do the timing prior to the surgery correctly, so the different drugs have different requirements. As you pointed out, cefazoline's now anytime in the first hour. Getting those kind of easy targets, and they're really good quality improvement ones, because there's something which is good evidence for, and the surgeons can actually see the benefits from that. And I think that's probably the main thing we can probably start with, is actually looking at one of the things which is the easiest to get on board with. The duration's probably a little bit harder. What was your opinion there, Trish? I can see you nodding.
Yeah, I mean, one thing that we've done, which was super easy, and when you think back, you go, oh, we removed all the 1 gram cefazolin vials from our adult theatres, and so everyone was instantaneously getting 2 grams, so appropriately getting the right dose, which it seems like a very simple thing to do, and it was, but it had a huge change in the fact that we were actually giving the right dose. So sometimes just simple things like that. The other thing we found was the cefazolin 1 gram had a similar coloured top to ceftriaxone. So occasionally the anaesthetists were pulling out ceftriaxone thinking it was cefazolin. So again, just a simple thing helped. But I think, with those projects, the first thing is to stop and understand the situation there, what's happening there, who have you got on side, and all of those very sort of simple things in theory, but always a bit challenging to do.
And then, I mean, I think especially when you're starting off with these, implementing AMS, I can't excel enough doing audits like the SNAPS audit or the NAPS audit to actually find out where your issues are, because you can't really, and as Sim kind of said, you can't find out what to improve unless you know where the issues are, and finding those audit results first. Working out where your main issues lie. Is it timing? Is it duration? Is it the wrong drug? Is it the wrong dosage? Really understanding. And again, from our point of view, it's actually the different craft groups are very different in the prescribing. So it is also targeting the messages for particular craft groups, because the orthopaedic surgeons are very different to the ophthalmology surgeons, which is different to the plastic surgeons. Their prescribing is different, and you've got to accept that, and you've got to really understand what the drivers are for each of the different craft groups and actually target those. So doing baseline surveys, finding out the important things from your facilities and in your countries, as opposed to others. Find the local prescribing guidelines, advertise those. All these things need to be done. And it's starting small, finding the data first, find some small little things you can improve easily, and that is probably timing and dose, and selecting the first drug be correct. And the duration is something that you can achieve later.
The other thing is you need to find your champions. So you find your surgeon or anaesthetist, and that's been really important for us here. But, you know, having a surgeon who's interested, who's engaged, who then goes and feeds back to their own team. I think we underestimate the importance of peer-to-peer review and peer-to-peer feedback. And I think once you've got them on board, you've really got a good advocate for change.
Yeah. And the thing is, your local champions are amazing, and you know, as soon as you kind of change practices of one, and people can see that there's no decrease in patient outcome, then it's easier to change other ones. Here is the age-old question though. How to change a surgeon's attitudes to the receptiveness of interventions from pharmacists, where doctor-pharmacist collaboration is minimal. This is an issue we are seeing all around the world, and for multiple issues around kind of AMS. Do any of the pharmacists want to answer that, and have they had the experience in Australia and find ways of communicating with surgeons?
Well, I will say from this particular project, yeah, it was having those representatives to kind of talk through. I was in a good position, or a lucky position, with accreditation, and slipping in some very powerful words into specific emails to particular people, I guess. So a few heads of departments have you put in, you know, accreditation and mandatory. That definitely got some drive happening, and then feeding it back through who they nominate as who they want to hear things from, kind of got them on board in that way of being a little bit more receptive from this project, at least anyway.
Courtney, you've done many interviews with surgeons. What's your opinion of that?
Yes, I was just waiting for it to go quiet again before I jumped in. I think also from a perspective of, like, I'm very fortunate to be in a role at the Alfred, where the Alfred is a very big advocate for pharmacists and their role. So I think it's a combination, it's a bit of a top-down approach in that retrospect, where the pharmacy service is well positioned to then have that liaison with the specialties, whether it's ID, stewardship, surgery. But in, say, I think Sajal's question referring to smaller hospitals where that doesn't exist, I think it's more, developing that rapport and relationship. Like, no one, it's not appreciative when, like pharmacist or a nurse just comes into the space with no context, no rapport, and wanting to generate change. I think that's a pretty common issue anywhere. So, it's going back to, how to get pharmacists involved is like that. I think, initially in a smaller setting, a more cautious approach, and, you know, wanting to give that feedback, but engaging with the surgeons in the first place. So it needs to be an internalized rather than external process. And with the qualitative research that we did do, a couple of the surgeons were, you know, all for a multi-collaborative approach, but at the end of the day, the risk and responsibility still laid with them, and therefore they still wanted to be overseeing the processes and the decision making. So I think it's understanding that context and where to position yourself in that. So I mean, the pharmacist is not going to be the dominant profession in this area, but we can definitely assist and help and optimize care. So.
And I think it brings back to Trisha's point. If you have a local champion, and if the pharmacist does the kind of presentations with that local champion, and they're supportive of the pharmacist's things. And again, if pharmacy has data, so again, if they've got some data to back up their claims, and again, the SNAPs and other audits of similar kind of data is very useful when you're actually talking to surgeons and talking about AMS initiatives and processes. And having an internationally recognised tool like the SNAPs, hopefully, is probably better. And definitely from our responses from the low and middle income countries using the hospital NAPS tool, having a validated international tool really does help to bring that message home. So those kind of things do help.
And I think in Australia as well, like Australian pharmacists are very well embedded in stewardship. And I mean, we know like from an NCAS surgical NAPS perspective, like we deal with a lot of pharmacists that are collecting the data, driving the data. So, you know, they're a key reference here. Like it's just then how you then disseminate that data, that it's meaningful to the clinicians and engaging with them to generate that change. So.
And I see that Kaz is biting the chip to get some questions out. So Kaz.
Morning, everyone. I just wanted to ask each of the panelists, because we experience this ourselves, exactly how do you organise a meeting with the surgeons? When? What do you do? What time do you meet them? How many do you get? I mean, these are really practical questions. I know from when we're organising the qualitative surveys, how hard it was actually to work out a time when they were happy to do it, because it means time out from the busy schedules when they're working between public and private. So I'd like a comment from each of the panellists in what they practically did.
Oh, I can speak first for our qualitative project. So, I mean, I obviously wasn't working full time because I was doing my PhD full time. So I had to be very flexible, and I obviously was fortunate to have that flexibility. Some were very early in the morning, some were late at night, and a key driver was providing some food, some snacks, and letting them know that it wasn't going to go for too long. And when we designed the questions, a big thing was, you know, surgeons don't want to sit and talk for 2 hours about this. If we can capture them, have like some key questions, get their attention for 20 minutes, 30 minutes, maybe a little bit more. But yeah, so be concise, have food, and a time that's going to suit them best, and we need to be flexible to them.
Trish?
What do you think, Kaz?
Yeah, Trish?
Yeah, I mean, that's the important thing. I think you've got to just bite the bullet and know you're potentially going to be at a 6:30 a.m. meeting or a 7 p.m. meeting. So thinking that you'll get them at 9 o'clock in the morning is completely unrealistic. So I think that's important. They all have their meetings, so they actually are very good at having audits, of having regular unit-wide meetings. So it's good to tap into those and meet with that. But yeah, like Courtney said, you've got to be short and sharp. You've got to just only take a small amount of that time. You've got to make your messaging really crisp to them. And I think also just presenting them their own specific data is the most meaningful thing to them. They don't really care what someone in the USA is doing. What they want to know is what the surgeon next to them is doing and how it differs from them. And so providing that feedback in a short, sharp, fast way is important.
Trish, can I ask another question? What if someone was in a hospital where they just could not find someone who was on their side? What if they couldn't find a surgeon or anaesthetist to help? Or do you think there is always one, you just need to look for it?
I think there is always one. It's just sometimes tricky to identify them. I mean, I also work at the Epworth where, for example, our orthopaedic unit has over 50 VMOs who some just pop in for their surgery list on a Wednesday morning, and that's the only engagement they have with the hospital. So it can be tricky. I mean, the other thing that you can use is colleagues. So you may know an anaesthetist at the Alfred, and they may put you in touch with a colleague that they have at a different hospital. And I found that to be really useful, or engagement through their societies. So the AOA, ANSCA, the Cardiothoracic Society. So you use a number of different channels, but I do find peer-to-peer is really, really helpful. One, because they've sort of sifted through people so they know who is likely to be actually likely to step up to the plate and be helpful.
And Trish, just one follow-up, sorry, I'm asking all these questions, but in the private sector where the theatre nurses can be quite powerful, what role do they play?
Yeah, I think they can play an important role, and one of the great vehicles to help is through the checklist. The checklist, for those who don't know, it's a list that they all go through. Have we got the right patient? Are we operating on the right side? And one of the tick boxes is, are they getting antibiotics, or have they had their antibiotics? And it's all the team comes together, and it's an important point where they can begin to discuss things and check things. So I think that they can form an important role in that. The challenge we have, and as Courtney's work and Alex Broom and his team's work, and also as Mita Tirani's shown, there's such a strong hierarchy in the surgical world, and it is the surgeon, the consultant surgeon on top who ultimately has decisions. So you have to, you can't expect the nurse necessarily to go in and challenge the surgeon. That you're setting yourself up for failure if you're wanting that to happen. But they can start, you know, through those mechanisms, through the checklist and things, begin to advocate for change or for improvement. So, you know, leveraging what things that are already existence, that are already accepted, but being cognizant that you're working in an interesting cultural environment with strong hierarchy.
Okay, thanks everyone. So I think we've kind of gone over time, but I think an excellent session, and obviously some really good points coming out of it. And I think there is hope, and I think with the results of the surgical naps, we are seeing there is improvement over time, and we are definitely getting better responses and input from the surgeons, which is great to see. And especially with the Commission's involvement with the RSES and everyone else, and now, you know, with the SNAPS report now having craft grouped results, I think we are finally getting there, and hopefully we can improve things even more. So thank you once again to all panelists and all attendees. I will plug a few more sessions coming up. I know it's probably a bit of fatigue for everyone, but we have an excellent session this afternoon on paediatrics. So if you're interested in paediatrics, it's an excellent one. One tomorrow morning is very interesting. It's on how to increase your capacity with antimicrobial stewardship, and looking at, you know, technicians' roles and things. So it's very interesting to see kind of branching out to more diverse use of staffing within the hospitals. And our final session tomorrow, to wrap it up, is on quality, and quality is what we want to get. So hopefully we can stick around and see some of those sessions. As a reminder, all sessions are being recorded and available on the NCAS website. And I'm sure if you send us any questions that you have from those sessions, we can forward them on to the respective presenters to answer those for you. But thank you so much for a great session. Thanks all to our speakers, and catch you again soon.